So some of the provocative tests for the vestibular system are listed here. In the picture here, this is the sideline test where the individual has their head turned, and it's somewhat like a Dix-Hall-Pike maneuver, where you're trying to get different angles on the semicircular canals, that are vertical, horizontal. So let's see if we can get this video to work.
And now the eyes are beating to the left. And do you have a little dizziness there?
Yes.
Okay, let's just see how long that lasts. That's what we expect when there are crystals in the horizontal canal.
It took a while for it to do that.
Okay, I'm going to turn your head to the right now. And on the right, we have some dizziness. That's quite strong. And to the right. Did it feel stronger to you?
Yes.
Okay. All right, I'm going to turn your head all the way.
So that was a good example of where rotation of the head to the right had a little stronger induction of nystagmus, and you notice that it was beating medially rather than laterally in this particular maneuver. So let's see if we can get to the next slide here. Okay, so this is an example of rotatory nystagmus. This actually made me dizzy watching this. Good gracious. So this is really an exaggerated form of rotatory nystagmus. They're often more subtle than that and are picked up on video nystagmography. So the Dix-Hall-Pike test is as described there. You have the individual sit in the clinical table. You turn their head to either the right shoulder or to the left shoulder, and then you guide them down. Don't let them flop down to the have their head dangle lower than the table itself. Now this maneuver is really hard to do in older adults because a lot of them have cervical arthritis, cervical neck arthritis, and I always find it very difficult to get them to lower their head below the horizontal of the clinic table. But nonetheless, this is the procedure that you need to do for Dix-Hall-Pike maneuver. Some of the other tests that we need to consider are to look for anemia, calcium and electrolyte disorders, both vitamin B12 and folate deficiencies, particularly folate in the diabetic patient, as well as thyroid disease. So hypothyroidism is often associated with both hearing loss and with vestibular disorders. You might want to consider audiometry, particularly to help you look at cochlear symptoms such as tinnitus or asymmetric hearing loss, and it may help differentiate between acoustic neuroma and Meniere's disease. This is a picture of goggles worn by an older adult where different provocative images are provided to allow the eyes to track with this procedure called video nystagmography. I myself had performed video nystagmography in our geriatric clinic quite successfully. We used it both for diagnostics for central and peripheral neuropathies associated with vertigo, but we also used it for therapy, because you can, again, whatever procedure that you do for the video nystagmography, which includes like cold and warm calorics, saccadic pursuit, and a number of other tests, that whatever tests produce the vertigo, you can then use those and replicate them in short recurrent bursts to help habituate the response. So I'm a big fan of video nystagmography, but it's not available at all clinics. Further diagnostic testing might include EKG. You want to look for certainly prolonged QT interval in people that may be on more than one SSRI. Holter and event monitors usually are not too productive, but can be considered. Tilt table testing could be used for individuals with true syncope. Quite honestly, I don't use tilt table testing or make that referral much at all in the older adults. And of course, if you're looking at acoustic neuromas, tumors, cerebellar disease, neuroimaging with either head CT or MRI would be appropriate, as well as looking for things like normal pressure hydrocephalus, which may not contribute directly to dizziness, but may give that sensation of either lightheadedness or wobbliness is probably more the description. So I found this kind of interesting. Just want to share this with you. This is another maneuver for habituation for otolith
I woke up in the
disease.
morning, everything started spinning, and it's this violent, the room goes like a spiral into space. You know, you feel like you're flying off the bed. I knew immediately what it was because this is my job. So we have the cochlea, the hearing part of the ear, and then we have the semicircular canals, the spinning sensors. So what happens is the particles that are in the utricle can sometimes get into this opening. When you lie down in bed at night, the particles can just fall in by gravity. And then when you sit up in the morning, they get all the way down here to the bottom of the ear. But when the particles build up to a big enough clump that they form a piston in the canal, then when you move your head like this, the particles move a sensor in this structure, and you feel that is spinning. And I knew that the particles were here, located in this ring. And so I had to figure out how to get them out. So I made a little model with my hands like this, and I twisted and turned it, figuring out a new way to do it. And I realized if I went forward, I could get the particles out. I made up the half somersault, did it, came up, and it was gone. So you start on your knees, and you tip your head straight up to look at the ceiling. And you hold that position for a few seconds. You'll usually feel a little bit of a spinning when you do that. That helps start the particles moving. Then you put your head completely upside down, tucking your chin a little bit so your head isn't perfectly vertical. It's actually tucked under slightly towards your knees. So during that time, you turn your head towards your right elbow if you're going to treat the right ear. If you're treating the left ear, you turn the head to face your left elbow. The side that you get the most dizzy when you're lying down and rolling over. So if you roll over to your right and that makes the spin, and you roll to your left and it goes away or it's not as bad, then you have it in your right ear. In that position, the particles will start to move and you will feel the spinning. You wait for all the spinning to stop, or you can count to 30 and then very quickly raise your head to back level. So your head and your back are on the same level, but you're keeping your head turned at that 45-degree angle. Then you again wait for the spinning to stop, 15 to 30 seconds, and then you bring your head fully upright so that you end up kneeling again. And in that position, the particles should leave the ear. But sometimes it takes 4 or 5 repetitions. The safest thing is to repeat it with 15-minute breaks between each attempt, because that allows the particles to fully settle out away from the opening. If you can't get rid of it, even after trying it repeatedly, you can always see a doctor and go in and have other maneuvers done.
So I think that's really a great example of habituation therapy for otolith disease. So let's get to the next slide. So in terms of management of vertigo, we want to look at benign positional vertigo. So there's the Epley maneuver, which is very similar to the Dix-Hall-Pike maneuver. but basically occupational therapy or physical therapy can do vestibular rehab. So that would be the referral of choice. In terms of Meniere's disease, some suggestions are to have salt restriction, to use diuretics, and also to use a vestibular suppressant such as meclizine. In severe cases, you might consider a referral to the ENT service for decompression therapy. They basically it's a over pressure within the cochlea that needs to be relieved. And then in terms of medications that might be associated with vertigo, stopping if they're on chronic immunoglycosides, switching from diuretics to some other type of antihypertensive, and to discontinue the nonsteroidal anti-inflammatory medications. In terms of pre-syncope, the big issue there is to treat with hydration, particularly if there's orthostasis. One of the axioms in geriatrics is to avoid dual alpha and beta blockade. So if you had somebody on terazosin, minipress, plus a beta blocker, usually not a good combination. So particularly in men where the alpha blockade may be used, like Flomax, for prostatic hypertrophy, it may be better to put them on finasteride as an alternative, because they're both actually equal in their ability to reduce blockage in benign prostate hypertrophy. Other recommendations are to kind of tell the patient to take it slow, get it slowly up, rising from sitting or lying down, wait, maybe tap your feet a few times, and then to get going. Also, compression stockings are an important adjunctive therapy. Also, referral to physical and or occupational therapy. And then as a last resort, in cases such as Shy-Drager syndrome, you may end up using fludrocortisone or midodrine is indicated. In terms of postprandial hypotension, recommendation is to use small meals and to avoid excessive exertion after eating. And as we saw by the graph, it can last for a couple of hours after a meal. So it's important to keep that time zone in mind. In terms of disequilibrium, things or conditions that are associated with ischemia, it could be TIAs, for example. You want to use antiplatelet therapy. Also to recommend postural therapy or gait stability through physical therapy. If there's an acoustic neuroma, referral to ENT or neurosurgery would be useful. In terms of Parkinson's disease, appropriate medications and also rehab therapy. Also to point out that exercise in Parkinson's disease is better with bicycle therapy than with walking. For some reason, the pedaling is less problematic, in terms of gait and balance. In terms of peripheral neuropathies, I think that's pretty straightforward with either vitamin replacement or treatment of hypothyroidism. And in terms of cervical spondylosis, you can again go through rehab. Surgery is may be indicated, particularly for severe spinal stenosis, but my experience is that it doesn't always help in the long run. So to manage other forms of dizziness, we need to consider psychogenic etiologies. And so either psychotherapy or antidepressant therapy to deal with either depression. So SSRIs, you want to avoid the SSNRs. You don't like to use the norepinephrine type or class of antidepressants. Those tend to have more side effects in the older adult. terms of the management of mixed etiologies of dizziness, you want to look for medication issues, and you want to discontinue or give a trial of medications that you consider causing the dizziness. And then sometimes both cognitive behavioral training can be an important intervention, as well as medication management. So I just wanted to show Epley's maneuver, and this is the different positions. Like I say, it's basically have a position sitting up, and then lying down where you rotate your head. You're in the Sims position here, and then you have head rotations to the left and to the right. And this is usually good treatment for benign positional paroxysmal vertigo. So I want to talk a little bit about research. A recent study here from Italy using polyphenol mixtures. They call it vertagogol, if I pronounce that properly. And it's apparently in a small study of about 120 patients per control and intervention arm, they found that it reduced subjective sensations of vertigo or dizziness, but there was not objective findings when they did the provocative testing. Interestingly, a study from Europe called the Revert Vertigo Registry found that over 90% of the individuals that had vertigo improved over time. And I just want to mention that ginkgo has been used for treatment of vertigo, and I just didn't see a whole lot of evidence to support it. But you may see folks taking that as a non-medical medicinal. So to summarize, the precise classification of dizziness into the concepts of true vertigo, pre-syncope, disequilibrium, and lightheadedness can be a challenge for the clinician. So that's why it's important to do a structured exam and get a good history. Most dizziness will resolve, and it can be habituated. So those are all the reassuring aspects in discussing the problem with the patient. And then always keep in mind that while you may do a good medication history, that half of the patients don't volunteer the fact that they're taking over-the-counter supplementals, or perhaps a spouse or a friend or another family member's medication or supplemental. So it's always important to really do a deep dive in the questioning about their medication use. Some of the key physical exams include mandatory check for orthostatic hypotension, and performing different provocative tests like the Dix-Hall-Pike maneuver, as well as observing gait. And the fundamental treatment of dizziness needs to focus on the underlying etiology or disorder. So that's the end of this presentation. I appreciate your attention, and look forward to having you view some of the other presentations that we have on principles of geriatrics. Thank you.